Hello, I'm John Joerns. I'm a transplant pulmonologist and intensivist at Mayo Clinic in Rochester. I'm going to speak for a few minutes today about transplantation for rheumatic lung disease, um, a real option. So, lung transplantation in rheumatic disease, a real option. First, a little bit about lung transplant. Modern lung transplantation started in the 1980s, and right now we have an average survival after transplantation of about 6 to 6.5 years. The most common indications are interstitial lung disease. Most lung transplant patients are maintained on three-drug immunosuppression, usually prednisone, a calcineurin inhibitor, and a antimetabolite, either azathioprine or typically mycophenolate. The most common rheumatic diseases that go into lung transplant are scleroderma, rheumatoid arthritis, undifferentiated connective tissue disease, and Sjogren's. And there's data coming out to suggest that many patients with IPAF also go on to lung transplantation. There's a lot of challenges here with nomenclature, and records are not very accurate in capturing all of these. And please remember that there are rheumatic manifestations other than interstitial lung disease, including pulmonary hypertension and obliterative bronchiolitis that go on to lung transplantation. Lung transplant pulmonologists are often hoping that they'll be able to find patients that have isolated lung disease. Complex multisystem diseases are worrisome for a transplant pulmonologist, but they are common in our rheumatic disease patients. Just to give you some idea, if we think about rheumatic manifestations and what the transplant pulmonologist may be concerned about, if we hear pleuritis or pericarditis as a transplant pulmonologist, I'm worried that there's going to be surgical adhesions that may make the surgery more difficult. If I hear about renal involvement in lupus or scleroderma, I'm going to be worried that tacrolimus may not be tolerated well. If the patient is a woman, especially that has had children, I worry that there may be autoantibodies or HLA antibodies that may make it difficult to find donors. If there's esophageal dysmotility, sicca symptoms, GERD, I worry about kind of multi-compartment gastrointestinal challenges that may increase the risk of aspiration, pneumonitis, or chronic rejection. Pulmonary hypertension, I worry that that could be a more challenging perioperative course. If there's antiphospholipid antibodies, whether or not there really is an antiphospholipid syndrome or not, we worry about increased risk of thrombotic complications, Raynaud's, skin changes, neuropathies, other MSK complaints. We might worry that these are either portals of infection or that a patient may be unable to rehab and have threatened functionality. And if there's neuropathies or other things that would threaten the diaphragm, we worry that we may get fresh lungs in, but that the benefit would be truncated by diaphragm disorders. And so historically, there's been a lot of concerns that rheumatic disease patients are difficult to transplant, that they may get suboptimal outcomes, and that they may have suboptimal survival. And this data, I think, has kind of best been put together so far in an ISHLT consensus document made with pulmonologists, rheumatologists, pharmacists, surgeons in 2021. They came out in 3 parts, and they address this head on. The historical perception that rheumatic interstitial lung disease patients, and scleroderma in particular, do not do as well is not really consistent with the available literature. Just to quote from the guideline, they say that transplant centers in both US and Europe have consistently reported that outcomes in patients undergoing lung transplant for scleroderma are comparable to those that are transplanted for other interstitial lung disease. Now, it's important to note that many of those patients with other interstitial lung diseases like IPF are often older, but still. When we're trying to think about rheumatic disease patients that go on to lung transplant, it's helpful if their disease is controlled, just like any other interstitial lung disease. There is some evidence, mostly taken from other interstitial lung diseases, that anybody who's transplanted from a flare may have suboptimal outcomes. And when we're trying to think about rheumatic manifestations that may need additional immunosuppression beyond those three-drug immunosuppressants, you can see here, I've just taken, if you consider the options for rheumatic interstitial lung diseases, you'll see that a common theme, whether it be systemic sclerosis, myositis, mixed connective tissue disease, rheumatoid arthritis, Sjogren's, or potentially even IPAF, While they all have slightly different toolkit, rituximab is considered first-line therapy in all of those. And so it's a broadly applicable tool that can be used to help control rheumatic diseases going into transplant, can be used peri-transplant, and can be used after transplant. And it's a medication that both rheumatologists and pulmonologists are going to have substantial familiarity with, and transplant pulmonologists are going to have substantial familiarity with. ICLT consensus statement does address a variety of different rheumatic agents and whether or not they can be continued off after transplant. And while I don't want to go through all of those agents here, rituximab has reasonable evidence. It has been investigated as induction therapy in organ transplants, including thoracic organ transplants. And while, of course, we have to be aware using rituximab, especially on top of people that may be getting induction immunotherapy and 3-drug immunosuppression, the ICLT consensus statements do recommend rituximab as being a medication that can be continued before transplant, peri-transplant, and at post-transplant if needed to control an underlying rheumatic or connective tissue disease. So there are a few kind of absolute contraindications that are specific to rheumatic disease patients. If a patient has active myocarditis with refractory heart failure, if there's active and uncontrolled extrapulmonary manifestations, for example, skin necrosis and non-healing ulcers, if there's upper airway lesions that would not be removed with the transplant, like subglottic stenosis or cricoarytenoid arthritis, if there's severe swallowing dysfunction with recurrent aspiration, that is not thought to be amenable to therapy. Oftentimes, this is dealt with a period of NPO where a patient is tube fed for a while. If a patient's unwilling to go down that path, that can be an absolute contraindication. Severe unstable atlantoaxial joints at high risk for subluxation, symptomatic arthropathy despite optimal control of disease, diffuse or focal proliferative lupus nephritis, evidence of active muscle disease that cannot be controlled with standard post-transplant immunosuppression. These might be a few of the absolute contraindications that are specific to rheumatic disease patients. While there's much to say on this subject, in short, many of the historical beliefs about suboptimal outcomes in rheumatic disease patients with interstitial lung disease or pulmonary hypertension that go on to lung transplant have not been borne out. I want to highlight two in particular, ANCA vasculitis and MDA5 myositis, as being particularly scary from the transplant pulmonologist point of view. We worry that the ANCA vasculitis could return, and there are a few case reports of that. We also worry that you might get more extra pulmonary manifestations in the vasculitides. And MDA5 myositis is notorious for very advanced lung disease, requiring lots of immunosuppression, being very fast progressive, with many of these patients having to be supported or bridged with ECMO. Most extrapulmonary manifestations are controllable with standard 3-drug immunosuppression post-transplant. Some things that I have seen include joint disease and rheumatoid arthritis and Raynaud's and scleroderma, with the usual toolkit that you would already be using for scleroderma, Raynaud's being available after transplant as well. Rituximab is broadly applicable in rheumatic pulmonary diseases. It probably has the most safety data in solid organ transplant and is the most guideline-supported anti-rheumatic drug to use peri and post-transplant if you need something beyond the 3-drug immunosuppression. Of course, other things like Plaquenil can be used, but if we're trying to look at TNF inhibitors and JAK inhibitors and a variety of the other anti-rheumatic drugs, rituximab probably has the most accumulated safety and familiarity data. And the more you refer to your local or regional transplant program, the more likely they are to partner with you. And hopefully together, you can offer transplant to many more rheumatic disease patients than has occurred in the past. Thank you very much for your time.